Hi, I'm Dr. Robert Glatter, Medical Advisor for Medscape Emergency Medicine. Today we'll be discussing an interesting study that was published by Dr. Austin Killaroo, an assistant professor at Penn Medicine, and his colleagues. And they looked at return visits and readmissions for ED patients diagnosed with COVID-19 within 1 week of their initial diagnosis and visit. The study found, interestingly, that slightly under 5% of the patients returned to the hospital and were admitted just within 3 days of their initial ED visit, and just under 4% were hospitalized within a week. Overall, it's about 9% of patients being readmitted to the hospital after their first ED visit due to COVID-19. Dr. Ali Raja, Associate Professor of Emergency Medicine and Executive Vice Chair of Emergency Medicine at Massachusetts General Hospital, will also be joining us to discuss this important research. Welcome, gentlemen.
It's good to be with you. Thank you for having us, Rob.
Yeah, we really appreciate it. So Dr. Killer, I'd like to begin with you, and you can maybe review your study design, your objectives, and your implications, for the study and your motivation, obviously, to do the study.
Absolutely. So the motivation for this study actually came out of a conversation I had in March with one of my colleagues who was working next to me in the emergency department. And we just started to see more and more patients with COVID-19 in Philadelphia. And we both had patients that we were managing and trying to decide, what would be the best plan for those patients. My colleague had a patient who looked very well, was older, and had findings of pneumonia on a chest X-ray, and asked me, what do I do with this patient? Do I send them home? At that point, our hospital was not having any issues with capacity, so we would have been able to find a bed for that patient. So with that in mind, we as we continued to progress with the pandemic through March, April, May, and June, we noticed that some patients were coming back to the hospital after being discharged from the emergency department. I think that in combination with the fact that this particular virus seemed to be acting differently than other viral illnesses that we see, in that patients have somewhat delayed worsening in symptoms. So the traditional, message that we tell patients to, you'll be better in 3 to 5 days, that didn't necessarily seem to be applying to all patients with COVID-19.
What were the main reasons you found for return visits when you looked across the board? What were the main criteria? And if you could talk about maybe the age distribution and what you were finding in that context.
Absolutely. So the specific paper doesn't mention the exact reasons for the return mission. That being said, data that we did not report in the paper indicates that most of the patients that returned with respiratory issues, worsening shortness of breath, and in some cases respiratory failure. We also had some patients that returned reporting worsening fatigue, dehydration, and other sequelae of prolonged viral illness. As you noted with age, we found that age was a significant risk factor for returning to the hospital after initially appearing well and going home. When we adjusted for other characteristics of patients, found that patients over the age of 60 had almost 3 times the rate of returning to the hospital. And those issues around shortness of breath, fatigue, and basically kind of decreasing ability to remain at home and to be supported at home. Those are the reasons that older patients were coming back to the hospital.
Absolutely. So when we talk about return visits, we're always thinking, did we miss something when a patient bounces back? With COVID-19, though, certainly there's a spectrum or evolution of the illness itself that we're learning, and that certainly when patients want to go home and they're stable, they can go home. But in your summation, do you feel that looking at the patient population that anything was being missed, or was this just the spectrum of the illness in and of itself that we're learning about?
I think that's a great question. Just like you mentioned, we're tracked on our bounce backs. Bounce backs are never desirable. Again, we didn't specifically look at whether some of these return visits could be called mistakes. I think, particularly the time, the patients that we were looking at, March, April, May, we were all learning about this illness and how to manage it. I will say that for the most part, the patients that were sent home were stable. And wanted wanted to go home. The physician and the patient probably together, decided that that was the appropriate plan of care. So I don't see these return admissions being bounce backs or failures. I think it is mostly a sign of a illness that continues to progress and may worsen for some patients, with somewhat unpredictably, but also with some predictable risk factors that you can expect. But that one initial evaluation in an emergency department or by a clinician may not be. It's just a single snapshot in time, and that as things evolve, patients may very well need an additional evaluation or a higher level of care.
Right. So Ali, I want to bring you into the discussion. In your experience at Massachusetts General Hospital, what type of situation are you seeing in terms of bounce backs, revisits, readmissions? Can you talk to us about your experience?
Thanks, Rob. And I think that we are seeing very similar findings to those noted by Dr. Killeru in this study. And I have to say, this was a great study, and I love it for a number of different reasons. The first is that it began when you were on shift talking to another physician, and she or he brought this question up. And that's how the best studies are begun. It's from a real clinical need, a real clinical question. The fact that 1 in 12 patients are bouncing back within a week of discharge is not surprising to me. Remember that while when all of this began a few months ago, like you talked about when the study was first thought of, when all this began, we had plenty of room in the hospital. But unfortunately, as the pandemic spread, as we found our hospitals getting more and more full, I mean, in our emergency department, in our hospital, in the months of April and May, we often had 140 patients who were in ICUs, and typically we have between 70 and 90 ICU beds. So this was a situation where we had to limit resources, so we were discharging patients who we might otherwise have kept in the hospital earlier. I think this study is also great because of the fact that your main findings, things like age, things like fever, things like oxygen saturation, those are things that patients can measure at home, especially the fever and the oxygen saturation. So like you said, Dr. Killeru, if we have a snapshot of what they look like, but when they go home, your study's actually given us the fact that if their oxygen saturation was initially bad when they first came in, or if they had a fever, they were more likely to bounce back. And this supports the fact that, like a lot of us do, we tell patients, keep checking your temperature, keep checking your oxygen saturation. If it starts dropping, call your doctor and consider coming back.
Absolutely. So, Austin, so if you could expand a little bit about your monitoring system at home. You mentioned in the article it's a text messaging based system. Maybe elaborate on that, and is there any video capability?
That's a great question. We actually have a few different monitoring systems that we've launched at the University of Pennsylvania, and some of them have some video capability, some of them don't. So the COVID Watch program, and I'll refer the audience to an article published in the New England Journal of Medicine Catalyst on this program. Is a automated twice daily text message based system where patients that are enrolled in this program can be from the emergency department, can be in the outpatient setting, even patients discharged from the hospital. They basically receive an automated text asking how their symptoms are doing. If their symptoms are worsening, or there are other problems that these automatic tests are detecting, then the case is escalated essentially to a pool of clinicians that can further triage or answer questions for the patient. We're currently evaluating the effectiveness of that program in terms of being able to keep healthy patients at home while bringing the patients that need to come back to the hospital. But in general, this program is loved by both patients and clinicians because it really reduces some of the burden on outpatient offices, for instance, that might otherwise be inundated with calls about symptoms. We've also partnered with our home health colleagues and our Penn Medicine Home Health agency to enroll particularly older and sicker patients who want to recover at home, and are then provided with home health services, including visiting nurses, and there is some telemedicine built into the monitoring that the home health providers are offering.
Yeah, Ali, so and would you echo that experience at your shop in terms of home monitoring? Do you have any kind of system set up with Mass General to monitor discharge patients and, obviously for decompensation?
It's a great question. We don't have as fancy a system as the Penn folks do. This COVID watch sounds fantastic, and I just started looking it up in the NEJM Catalyst, and it seems like there's been a few thousand patients who have already gone through that. In general, what we had was a tiered response. For most patients, I would actually just tell them to stop by the drugstore and pick up a $20 or $30 oxygen saturation monitor and a thermometer and do those and check their oxygen saturation, especially with ambulation, not just while sitting around or lying around. But we also set up a system where local paramedics partnered with us and did home health visits with paramedics. We also have a home hospital system, much like the one at UPenn, that involves either nurse practitioners or physicians going by and visiting patients in their houses. We also, I think this was all a great opportunity for all of us to expand upon our somewhat nascent telemedicine systems. And this allowed us to set up systems where patients could telephone in or video call in with their primary care physicians, so that if they started feeling bad, they didn't have to try to come right back to the emergency department. They could get their doctor on the phone and she could guide them based on what the symptoms they were feeling and what kind of temperatures and what kind of oxygen saturations they were experiencing.
Moving on to a different topic, looking at racial disparities and how that may have contributed to the readmission rate upon patients that were discharged. Austin, do you have any data on that from this study to really link that, in other words, to the different demographics of your patients, their rates of infection and so forth?
Thank you for asking it. I think the relationship between race and COVID-19 is so complicated. In our study, we did include race as a potential risk factor. I'll note that the population that we studied, over 50% of the patients were African American. We did not find that race was a statistically significant predictor in whether patients needed to return to the hospital for an admission. That being said, I think that patients, these are patients that were already seen and evaluated in an emergency department. We know that in our community, and in West Philadelphia, where my hospital is located, that Black patients have a much higher rate of contracting the virus in the first place, and the fatality rates, the mortality rates are higher for our population. So while we didn't find that specific finding in our study to be a risk factor, we're still very concerned about the differential outcomes for patients that are Black with COVID-19.
Right. And Ali, if you could comment on that as well, your experience at your institution.
I think, Dr. Glatter, that Dr. Killeru hit the nail on the head. While that may have not borne out in this particular study with the subset of patients who were discharged and bounced back, the fact is that the hardest hit parts of Boston have been the places that have the patients with the lowest socioeconomic status, and unfortunately also happen to be places where there's predominantly people of color and non-English speaking patients. And we found that not only were they unfortunately hit harder than white English speaking patients in the city, but on top of that, even when they came in and seemed to be equally ill, care was just a lot more difficult. And so, for example, having end of life or goals of care discussions with patients while using a phone interpreter when everybody's wearing a mask and there's a fan going off in a negative pressure room is so much harder than being able to just have a face-to-face conversation with an English-speaking patient in the same scenario. And so we found that we had to set up systems of care to help take advantage or to help give those patients care. So we, for example, had a Spanish language care group where we had everybody from general surgeons who spoke Spanish to psychiatrists who spoke Spanish, who specifically came into the emergency department to have these critical conversations with our critically ill patients, so that we didn't have to go through an interpreter or try to communicate in ways that weren't optimal. We all had to set up systems in place, and I'm sure the same is true in New York and Philadelphia, to make sure that we gave patients equitable care despite the language barriers and despite the fact that they may have come from communities of color where primary care might not have been as available as it was in other settings.
So all in all, I guess the takeaway I'm getting is that older people, greater than 60, people that are hypoxic at presentation, Dr. Killeru, these are the people we need to watch and maybe reconsider about sending home But that said, if there is appropriate monitoring in place, that it's something to consider upon discharge.
I'll just add that, our goal for the study, both in the design of the study, is not necessarily to really, direct emergency clinicians to say you should be sending home these patients or you should be admitting these patients, because ultimately that decision is part of our practice. That's kind of what we're trained to do, is to make those decisions. I think the real, what I'm hoping that the impact of the study could be is that we are able to have more informed conversations with patients, to really take the time, which can, honestly be challenging in an emergency department. And, we want to limit our contact in some cases with patients that are suspected to have COVID-19, but we do really want to take the time to have these conversations with patients to advise them that their symptoms could potentially worsen, to make sure that they have a plan in place for if they are getting sicker, that they know what to do, whether it's through, the programs that we've talked about, or just through calling their doctor. So, I think that is the goal. We were finding that there are predictable risk factors for reasons that patients come back to the hospital. But I think with any patient that you're sending home with COVID-19 and that you're concerned about, we want to provide them with the most up-to-date information on what they can expect during the course of their illness.
Hey, Dr. Raja, would you want to add anything to those comments?
I think that, as Dr. Killeru said, Dr. Glatter, this is such a scary diagnosis that being able to provide patients any statistics that allow them to be somewhat reassured about being discharged home help. But a study like this is great because we know that the right thing for these patients is to be treated at home, both from a hospital capacity standpoint, but also so that they don't get other hospital-acquired infections. But sometimes patients come in and think, oh, I've tested positive for COVID-19, I should automatically stay in the hospital. And being able to use data like this to say, no, you can actually be safely cared for at home, allows us to fall back on this kind of great study. So thank you, Dr. Killeru, for you and your team's work on that.
Yeah, I want to thank you both. This has really been an informative discussion, and I think it gives us some guidelines to look at, but certainly shared decision-making is the most important thing, and a patient's comfort as well. Thank you again, both.
Thank you. Thank you.
Thanks. Thanks.
Thank you. Thank you.